So officially first is supposed to be Dr. Maurya's team, but they are not here. So the first team that is going to present is Team Visionaries, Pallavi Garg and Anaga. Your PPT is uploaded? Okay. So one of you please come there. Your mentor will decide the sequence. Whoever wants to present, come here first. ठीक है आपका तो लास्ट है no both of this time we are changing the sequence the both the team one presenter will present first, okay, then the second presenter the sequence will be reversed. So now only one team mentee is going to present, so you decide. So you are Anaga, so Anaga is presenting, right? And Anaga, your topic was management of acute optic neuritis. Achha, you are presenting Amsler, okay, fine. So Anaga is presenting Amsler chart. Yeah, please start. इनका दो.
Tips and tricks to keep the house cool.
Help us to check the central 20 degrees of the field. And so each small square subtends an angle of 1 degrees of field when it is kept at a reading distance of 30 centimeter. So normally when an object light falls on the fovea, a corresponding number of cones are illuminated, and the brain perceives the image of the particular shape and size of the same as object. But in cases such as central serous chorioretinopathy, central macular edema, it causes a dispersion of the cones at the fovea. So this will cause only a lesser number of illumination in the cones, and thus the brain perceives the image to be smaller than the objects, and this is called micropsia. Whereas in macropsia is caused when epiretinal membrane causes a traction which causes crowding of the cones, so that the same object now illuminates a greater number of cones. So the object image is also perceived to be larger. So indications for checking or using Amsler's grid is age-related macular degeneration, CSCR, epiretinal membrane, cestoid macular edema, hydroxychloroquine retinopathy. So how do we do it? So ask the patient to sit in a well-lit room, wear their glasses or give best corrected vision, ask them to close one eye, keep the Amsler's grid at 30 centimeter distance, and then check at the central dot. So this is the central dot. So when they check at the central dot, they should tell whether they are able to see the central dot first, whether they are able to make out all the corners of the margin of the square, and whether they are seeing all the grid correctly. Or if they are seeing any distortion, they should show it in the Amsler's grid as shown in the example. So, but what if the patient already has a central scotoma? Then they won't be able to fix it. So then we can use a type 2 chart which has diagonal lines which will help the patient to fixate on the central dot. Now type 3 is red lines in black background which helps to pick up subtle red desaturation which are seen in toxic maculopathies or bitemporal hemianopia. Now type 4 is used to differentiate between metamorphopsia and scotoma. So in this there are random patterns of white dots that are seen. Now type 5 is where there are 21 horizontal lines which are helped to check specific meridians or metamorphopsia. So we can turn the chart and they can check for metamorphopsia. Now type 6 and type 7 have lines near to the fixation, closer to the fixation point. So they detect fine metamorphopsia near fixation. They subtend an angle of 0.5 degrees. Now there are many modifications such as threshold Amsler's chart which they use cross-polarizing lens along with the normal Amsler's chart, and sine Amsler's chart which has increasing amplitudes of Amsler's chart. They help to quantify the metamorphosia and monitor the progression. So this is an example of sine Amsler's chart. So class, Amsler's chart is a very easy and cheap effective tool which can be used in home and for office setting for screening and early detection and to monitor the progression of the disease. Thank you.
Thank you. Meanwhile, the judges ask question. I request anyone from team visionaries to be prepared. Okay. Team visionaries.
We are
You are visionaries, right? Team UCMS. One of you please come here. इनका PPT यहाँ पर दो. Judges can ask.
Well presented. You said 5 types. So why we use only one chart? Do you have any practical experience of using the other charts?
No, ma'am. Usually we are using this chart mainly, which is widely used. So this helps in the when the black lines are more in the white background. This helps in more contrast also, and it's easier to see in the if it's illumination is not that correct also in the room. This helps in detecting better.
Do you think the size of the paper also matters if I print it on A4 paper?
Yes, ma'am, because only this particular size of 10 into 10 square, when it's kept at a 30 centimeter, it subtends an angle of 1 degrees. If it is kept in a different distance also, if it's a larger grid also, it subtends a different angle, so we won't be able to check the central 20 degrees of vision.
Correct. Thank you.
It can make a difference.
Yeah, these are available actually. So how frequently should one do this?
At least once a week they should check, sir.
This is what you will advise to the patient.
We'll usually give this to the patient to check it at their home or their office at least once a week, but more frequent also advised.
And when do you want them to report to you?
As soon as they find there is any distortion or any waviness in the, or even if they are feeling there is some decrease in their vision also, they should report to us.
Or if there's already a distortion?
If there is an increase in distortion from the baseline which they have already tested, like when we are giving the Amsler's chart for the first time and they are diagnosed, they are already know they have a distortion. So they have already marked it. If they are finding it has progressed it more or there is any new distortion that has developed, they should come and meet.
Thank you. So we have our next speaker, teacher, Dr. Pragya, and she is going to discuss about management of GRT.
So Shakespeare said, all the world's a stage. So too is the eye, where we ophthalmologists dare to operate. You see, the retina is like a canvas of light, delicate and vast. But when a giant tear unfurls, this canvas crumples and darkness spreads fast. Today I'll show you how to manage this delicate masterpiece, how to mend it part by part, piece by piece. So pay attention, ladies and gentlemen, to the stage over here. For today we're going to learn about the management of a giant retinal tear. First, we need to know how the curtain falls. So look here, ladies and gentlemen. The basic pathology is an abnormal vitreous and a weak retina. So these are the conditions of a weak retina. So what happens? The central vitreous liquefies, causes peripheral vitreous condensation, which exerts traction on the peripheral retina over here. Eventually, this peripheral retina rips circumferentially in a zipper-like fashion, causing a giant retinal tear.
Go little back so that judges can also see. और थोड़ा पीछे yes वहाँ से दिखाओ.
So once this giant retinal tear has happened, this liquefied vitreous can seep behind the posterior flap and into the subretinal space and cause detachment of the neurosensory retina from the underlying RPE. A giant retinal tear classically involves more than 3 clock hours of the circumference of the retina, and it might involve any quadrant. There is usually an anterior flap under which is the subretinal fluid, which can cause slippage later. And then you've got a posterior flap. The anterior flap has attached vitreous, the posterior flap does not. Because of a lack of attachment of posterior vitreous, this flap can roll and fold and invert, and that becomes a hassle to manage at the time of surgery. So now we also can have radial rips from the margin of the giant retinal tear, and there can be proliferative vitreoretinopathy. Now, how do we manage a giant retinal tear? So firstly, we need to take care of the lens. If there's a stable and clear crystalline lens or a stable IOL, then we don't need to touch it, we don't need to remove it. However, if there is significant cataract or subluxation or PVR, then the lens needs to be removed. The first step is vitrectomy. So first we need to remove the vitreous from the attached part of the retina and then from the mobile flap. And we have to remove as much vitreous as possible up to the very base. Now, the next step, we have to remove the anterior flap also because of the subretinal fluid, which might cause slippage later. Next, there might be any proliferative vitreoretinopathy or any folds which have to be removed so that the retina is uniformly flattened. Next, what we do, we use PFCL, perfluorocarbon liquid. So we have got the PFCL bubble. We inject it slowly through the infusion cannula over the posterior pole, the disc surface. And what this does is, this gradually spreads and it flattens out the entire retina up to the periphery. Now, the properties of the PFCL are as follows. So we have to be very careful that the PFCL is injected as a single bubble very slowly, because multiple bubbles or fish egging can go behind this flap and can destabilize the flap later. Now, the next step, the most important step is the PFCL oil exchange. But before that, once we have flattened the PFCL, when we have flattened the retina from the PFCL, we need to do retinopexy. How do we do a retinopexy? We take an endo laser and we do 5 to 6 rows at the margins of the GRD and 3 to 4 rows over the rest of the retina. The next, the most crucial step is PFCL oil exchange. We can do it as a direct exchange or in a two-step manner. First, we exchange PFCL with air and then we exchange the air with oil. Now, the mechanism of PFCL oil exchange. So we've got silicone oil. We are injecting it through the infusion cannula and at the same time, we are aspirating the PFCL through the suction catheter. So simultaneous removal of the PFCL and insertion of the silicone oil gradually fills the entire vitreous cavity with the silicone oil, and now there is a constant heavy liquid which is pressing down the retina and holding it in place. So this is how we do the exchange. So these were the basic steps of GRT surgery, and that is how from chaos to calm, from darkness to sight, science and art merge under the light. Thank you.
Thank you. Thank you.
Excellent
Wonderful
presentation.
ways, yeah. So meanwhile, when judges are asking questions, I request team from GlucoStars to be.
So, silicone oil is heavier than water?
Yes, sir, it provides a tamponading effect.
Is it heavier than water or lighter than water? And PFCL?
PFCL is also heavier than water. It has a higher specific gravity.
Then how will it replace?
Oh, sorry. PFCL is heavier in water, so it goes down, and silicone oil is lighter, so it goes up, and that is how it spreads. PFCL spreads, whereas silicone oil is injected.
So when we inject silicone oil,
Yes, sir.
we have to remove PFCL, no?
Simultaneously. Yes.
Yeah. So how will you do that?
So we insert silicone oil over the central meniscus of the PFCL, and then PFCL spreads to the sides, and we aspirate it from the cannula, from the site.
Okay, good. Thanks.
So our next team is team.
Pragya
Excuse
Gupta.
me. Pragya Gupta, management of GRT. Team UCMS. GlucoStar, Shibam, you are presenting?
Nirvan Datta.
Okay, good.
Good afternoon, everyone. I will be presenting on direct ophthalmoscopy, a window to the fundus. Ever wonder why we cannot see the retina with our naked eyes? Yes, retina is very reflective. Only one ray out of 10,000 to 1 lakh are reflected back. So we need a bright light to see the fundus. Funduscopy is the procedure to view the back of the eye, also known as the fundus. It can be done by direct ophthalmoscope, indirect ophthalmoscope, or slit lamp biomicroscopy with 90D lens. A bit of historical aspect, ophthalmoscopy was invented by Babbage. However, its significance was not recognized until von Helmholtz reinvented it in 1850. Coming to the parts, we have on the patient side, we have a mirror, aperture and filter selector. On the doctor's side, we have a doctor's eye window, a lens wheel, a lens indicator. We have a brow rest, a lens wheel to change the diopter, rheostat on and off, and a thumb rest. Coming to now the principle of ophthalmoscopy, if the patient is emmetropic, light rays are directed from a light source in the fundus are reflected as parallel beam. This parallel beam enters the pupil of an emmetropic observer. The rays are focused on the retina and an image of the fundus is formed. Image is virtual and erect and magnified by 15 times. Direct ophthalmoscopy, main thing is the optics of direct ophthalmoscopy. Considering we have an emmetropic patient and an observer, we have a light bulb, two convex lenses and a 45-degree angled mirror with a slit in between it. Light falls on this mirror and is reflected on the patient's retina, which the observer sees. We have an aperture in between which can be changed. We have a small, large, a cobalt blue filter or a red free filter and a fixation target. There is a convex or concave lens wheel which can be changed to emmetropize the eye. Equipments and patient preparation, mainly we need a dark and dimly light room, a mydriatic eye drop. Patient positioning is very important. Sit facing the patient at the eye level. Ask the patient to fixate at a distance object. At an arm's length, we start examining. We follow the red reflex, and we generally we do it. If we are examining the right eye of the patient, we use the right eye and we keep our left hand to fixate ourselves. Now, what to look for? First of all, we look for red reflex on distant direct ophthalmoscopy, any opacity in the media. Adjust the focus and examine the vessels, locate the optic disc and find the macula. There is a concept of parallactic displacement where if the opacity is behind the pupillary plane, it will move opposite to the movement of the observer. If it's in front, it will move with the movement of the examiner. As a beginner, we are taught like we have to find a vessel, we focus it, trace it nasally to find the optic disc, and 2 disc diopter from it we have the macula to see the fundus. Advantages are highly magnified detailed view of the central retina, portable, inexpensive and readily available, easier to use with undilated pupil, narrow field of view making peripheral retina examination difficult, lacks stereoscopic or 3D vision, difficult to perform through pupil, small with media opacities and examination is time limited due to patient discomfort. Next generation newer advancement is Welsh aligned panoptic plus ophthalmoscope, which has a 20x larger viewing area, quick eye trademark alignment technology and digital image capture, which helps in patient comfort. Easy, high magnification and high illumination is better with this type of ophthalmoscope. Thank you.
Thank you so much, and even I learned a lot about new things about direct ophthalmoscopy today.
I
And
want
in
to
the-
ask you a question as a
please.
student. What causes magnification?
Aapka turn.
It mainly depends upon the power of the eye. If it's high, if the power, in case of myopes, if the power is converging power is high, so magnification will be more.
So you said 15x, no? So it will more in myopes.
In myopes it will be more, and in
astigmatics, will there be anything?
In myopes it will be more, the field of view will be less.
Patient has astigmatism.
We have lens wheel to change the diopter of the, to emmetropize the eye, to change the diopter.
What is Reko's disc?
Yes.
Reko's disc.
Yes.
Lens wheel is called Reko's disc. Any other question?
Why can we not see a red reflex with a torch and see it with the direct ophthalmoscope?
Actually, we need a pinhole to see it. We can also see it through a glass mirror with a pinhole in between it, because all of the rays are not reflected back. Few rays are reflected back, so we need a pinhole to see through it.
So what is coaxial illumination?
Okay, next class.
Are the structures in the pupillary plane, they move with or against when you are doing the
Pupillary plane, they will be stationary.
nodal point or pupillary plane?
Pupillary planes.
I think it's a nodal point, Any structure in front of the nodal point of eye, which is just in front of the posterior surface of the lens, they move with, and others behind the nodal point move against. When you're doing distant direct ophthalmoscopy, right?
Next speaker. PPT though, AV team.
Good morning, class. I am Dr. Sadhja, and today I will be talking about a very important topic, that is management of congenital glaucoma. But a student may ask to a teacher, why this is important? Why do I need to even learn about this? So here I have compiled 3 studies that showcase the burden of the disease. Approx 3 lakh children are affected by congenital glaucoma worldwide, and among 2/3 of them end up with irreversible blindness. In India, the prevalence of congenital glaucoma is 1 in 3,300 live birth as compared to 1 in 10,000 live birth in world population. One thing important to note here is that these studies were conducted in tertiary setup. So if we take account of rural population, the actual burden may be very high. So I provide you a great opportunity to conduct research and fill this lacuna in our research. Recognizing the classical sign and symptom of a disease can greatly help an ophthalmologist in reaching a diagnosis. This chart here provides a step-by-step approach on how to reach the diagnosis. Now we have a diagnosis, we know the disease, now how do we treat it? We have 2 options available, surgical and medical. Medical management mainly act as a bridge to surgery. Beta blocker is first choice of drug in pediatric glaucoma. In case of insufficient control of IOP, we can use combination of beta blocker and carbonic anhydrase inhibitor. But a doctor must know, before knowing what to give, a doctor must know what not to give. Alpha 2 agonists provide a serious CNS toxicity due to their ability to cross blood-brain barriers, so they are absolutely contraindicated in children below 2 years of age. Please remember, class, that congenital glaucoma is a surgical disease. So what are the options available to us? First one is goniotomy. Here we make a limbal paracentesis, and then under direct gonioscopic visualization, a goniotomy knife is engaged with trabecular meswork just anterior to the scleral spur, making an excision into the abnormal trabeculodysgenetic tissue, excising up to 120-degree angle and thus opening up the Schlem's canal. Next one is trabeculotomy, independently described by Burian and Smith. Here, after making a partial thickness scleral flap, Schlem's canal is identified. Then with a trabectome, we insert it into the AC and rotate anteriorly. Similar thing is done on another side, thus opening up to 180 degree of Schlem's canal. It can be modified to do a 360 degree of trabectomy, which have better success as compared to 180 degree. Goniotomy and trabeculotomy are together known as angle surgery, and generally they are the first preferred choice in congenital glaucoma. But one thing determines that which procedure will be used when is the clarity of cornea at the time of presentation. Trabeculotomy can be combined with trabeculectomy in countries like ours, where children generally present late in our clinic with lot of corneal edema. But congenital glaucoma are resistant to treatment because of their inherent limiting factor associated with them. So how do we approach refractory cases? Glaucoma drainage device provide a good alternative in children who do not respond well to conventional angle surgery. The main aim of GDD is to create a shunt directly for aqueous humor from anterior chamber to subconjunctival space at the equator. Cyclodestructive procedure can be used as a last resort in refractory cases with very poor visual prognosis. Remember that requirement is a key to innovation. Over the time, we saw that these conventional surgeries were associated with lot of tissue disruption and many complications. So nowadays, we have come up with new technique like GAT, new shunting device like gel send, pressure flow, etc., which have proven good efficacy in mild to moderate cases in initial phase of research. So now we have treated the patient. What we are going to do now? Now we have to follow the patient regularly and see if our options are doing well with the patient or not. These are cycloplegic refraction is necessary every 6 months to control myopia and astigmatism. These are clinical pearls. Thank you.
Thank you. We can discuss all these things in next class probably, right, ma'am? Okay, any questions from the judges?
Which trabeculotomy you use? The name of some.
Harm trabeculum.
Yes, right.
Yes.
That's right. Yeah.
Yes. I am not.
Can we use a suture
Anjay?
to do
Yes, sir. 60, this circumferential trabeculotomy, we are using this 60 proline suture which is pulled across the anterior chamber to open up, do this 360-degree trabeculotomy. Yeah, that research has shown that it has a better success rate because it is done in one setup and it opens 360 degrees.
It's a very nice presentation.
Thank you, sir. Okay.
Thank you.
She's smiling, so that's good. And that's great.
Dr. Sagun. So Dr. Sagun is a speaker from Team Pupil Powers.
Good morning everyone. Today I'll be presenting on the workup of diplopia. What is diplopia? It is a simultaneous perception of two images of a single object that may be displaced horizontally, vertically or obliquely. So what is important in critical history taking? So first and foremost step in the workup of diplopia is to differentiate monoocular diplopia from the binocular diplopia. So we will ask the patient, does the double vision resolves on closing either eye? And it is important to note that we should not ask the patient that does the double vision goes on closing with one eye. Because if the patient happens to close the affected eye, then the monoocular diplopia may be misdiagnosed as binocular diplopia. So monoocular diplopia, the most important causes are the ocular causes, whereas in binocular diplopia, it indicates ocular misalignment as a major cause. So we should dig deeper into the history for binocular diplopia. We should ask for image separation, whether the images are separated horizontally or vertically. If the images are separated horizontally, then horizontal movers are involved and the nerve supplying them. If it is worse with distance, then it is sixth nerve palsy, and if it is worst with near, then it is medial rectus palsy. Also, we should ask for worst gaze is equal to the action of the parietic muscle. But in case of muscle restriction, it is opposite. We should ask for any neurological symptoms, clinical course, and history of congenital strabismus or any corrective head posture. So examining a diplopic patient, we should look for visual acuity. On inspection, certain points should be noted. That is the corrective head posture the patient adopts to minimize the diplopia. Like turn to the affected side is seen in sixth nerve palsy, whereas associated ptosis can be seen in third nerve palsy, myasthenia gravis or Horner syndrome. So pupillary examination is important. We should look for an isochoria. Mydriasis, more prominent in light, is seen in third nerve palsy, whereas meiosis, more prominent in dark, seen in Horner syndrome. In context of diplopia, it signifies cavernous sinus lesion. So the most important part of the diplopia assessment is extraocular motility. So if the motility is limited, then we should check whether it is paralytic or restrictive. That we will do by force reduction test. So if it is restrictive, it signifies orbital disease like thyroid eye disease or any Brown syndrome. If it is paralytic, then it signifies cranial nerve palsy. So if there is abduction limitation, that is seen in sixth nerve palsy. If the adduction is limited, either medial rectus is involved or there can be internuclear ophthalmoplegia, that is the damage to the medial longitudinal fasciculus, in which the convergence is spared. Elevation and depression can be affected in third nerve palsy, and also depression is affected in fourth nerve palsy too. But if the EOM is full and free, we should not stop. We should test for tropias and phorias by the various battery of tests, that is the cover test, Maddox-Raw test, Hirschberg test, prism bar cover test, to quantify the deviation. So if it is comitant, both for EXO and EXO and associated with AV patterns, it signifies infantile strabismus. But if EXO is present only at near, then it indicates convergence insufficiency, but only at far, then it indicates divergence insufficiency. Hyperopic esotropia is seen in accommodative esotropia. Whereas if the deviation is not equal in all the 9 positions of gaze, then it is incomitant and it signifies nerve palsy. EXO same. If the convergence is paired, then it is internuclear ophthalmoplegia. But if it is associated with ptosis, mydriasis and reversing hypertropia, then it indicates third nerve palsy. For esotropia in horizontal plane, it indicates sixth nerve palsy. Coming on to the vertical deviation, if there is hyperdeviation with comitant, which is comitant, then it can be congenital, or if it improves in supine position, then it is a skew deviation. For incomitant, reversing hypertropia is seen in third nerve palsy. If it is worse in adduction and elevation, then it is inferior oblique overaction. If it is worse in adduction and depression, then it is fourth nerve palsy. And in chronic cases, we can see both bilateral inferior oblique overaction with the fourth nerve palsy. If each eye is hyper in abduction, it is alternating skew, and if each eye is hyper in adduction, it can be bilateral fourth nerve palsy with inferior oblique overaction. So the structure is clear. First, differentiate monoocular versus binocular. In binocular, if there is limited extraocular motility, we will see for paralytic and restrictive, and for if the extraocular movements are full and free, then we should look for strabismus or any neurological cause. Thank you.
Thank you for that powerful lecture.
I think teacher is very clear about the concepts where the students are confused.
Just as usual with cases of squint, right? We are always confused. We need a repeat class of this. Okay, anyone from team Adesians, prepare your lecture there. In the meantime,
Thank you.
judges may ask you. Team Adesian, yeah? One of you have to present, come here and inform the AV team which part you are presenting. So what was the source of all your this flow chart or this thing, from some books or what?
Sir, I have read articles.
All are this from
Yes, sir.
article?
All
Okay.
the articles about workup
That's
of
good,
diplopia.
because the aim of this teachers of tomorrow, to make you people go through what a teacher go through when preparing for a lecture,
Yes, sir, I
right?
made a flowchart on by reading articles.
आ जाओ जल्दी.
Uniocular diplopia.
Sir, uniocular diplopia can be both bilateral or uniocular diplopia.
What is uniocular diplopia? You can say.
It is equivalent to monoocular diplopia. Huh? Yes.
What condition?
Sir, in cortical lesions, rarely it can happen.
No, think something else.
Sir, in any like tear film abnormalities occur. Yes.
Ectopyrelentis, keratoconus, early cataract, these are all causes of monocular
Monocular
diplopia.
diplopia.
Okay.
These topics given to them or they have chosen themselves?
We have given them, sir, 1 month before, so that they can prepare the lecture and take the class. Okay. Yes. Yes, Navneet, you can start. आप लोगों आपको लेट आ गया हो.
Student is saying कि I didn't get that much time to prepare this lectures.
See, that is also experience of a
he is
teacher,
student.
you get a notice one day before you have to compensate for my class. So that's also the experience.
Sometimes
Yeah, Dr. Avni.
10 minutes before class, then you just ask the questions.
Dr.
Deliver the
Navneet.
lecture, you keep asking the questions.
Good afternoon, everyone. So my topic is aqueous humor dynamics. So it is divided into two parts: aqueous formation and secretion, and aqueous outflow. So ciliary body is bilayered epithelium. Anteriorly pigmented epithelium is present, and posteriorly non-pigmented epithelium is present, which is towards the posterior chamber. So zooming in, this is the ultra structure of ciliary body. There are 70 ciliary process. This is a site of aqueous production. There are arterioles and venules and stroma in between, and anteriorly posterior pigmented epithelium and posteriorly non-pigmented epithelium is present. So this is the pathway of the secretion. So there are 3 steps. First step is uptake of the solutes and water from the plasma by pigmented epithelium. So aqueous humor is ultrafiltrate of the plasma. Second step is transfer from the pigmented epithelium to non-pigmented epithelium, and third is the release from non-pigmented epithelium to the posterior chamber. So 3 modes of transport are there. First mode is ultrafiltration, that is along the pressure gradient. Second is the active, which needs the ATP pumps, and third is the passive, which is diffusion along the concentration gradient. So pumps are sodium potassium pump and sodium hydrogenase. There is production of hydrogen ion, which leads to the drive of sodium and sodium and water goes out in the posterior chamber. So there is a main role of carbonic anhydrase, which leads to the release of H ion. So from posterior chamber to the anterior chamber, through the pupil aqueous go, and in the pupillary block there is accumulation of aqueous behind the iris, leading to the iris bombae. So quickly we'll revise the anatomy of angle. So this is how tubercular meshwork looks like for the second part of our class, that is outflow. So aqueous outflow is divided into 2 parts, that is trabecular outflow and uvuscular outflow. So trabecular outflow is the main, which is pressure dependent, and uvuscular is pressure independent. So trabecular meshwork through the Schlemm's canal collector channel, episcleral vein, and superior ophthalmic vein to the cavernous sinus, and uvuscleral outflow through the ciliary body band to the suprachoroidal space to the intact sclera, and orbital vein to the ultimately drains to the cavernous sinus. Thank you.
Thank you so much. In the meantime, when the judges
Outflow, pressure dependent
Ames
outflow,
Bhopal.
and uvuscular pressure independent. Why?
Sir, trabecular meshwork is mainly a major part through which the aqueous.
And why it is called pressure dependent?
So because of the pumps.
Pressure dependent, it's called pressure dependent because let's say you take 4 glasses of water, the aqueous production increases, so outflow also increases. With increase in intraocular pressure, the outflow increases, whereas uvuscular outflow is not pressure dependent, it's pressure independent. Clear? Okay, other question is, what is ultrafiltration?
So it is the passive along the concentration gradient.
Passive along the concentration gradient, how can it happen? So
Sir,
from the vessels,
Sir, from
plasma constituents move into the ciliary stroma.
Yes, sir. So this is
So constitution, it is against the concentration. But what is dialysis?
So,
What you are saying is dialysis.
yes, sir.
From the lower concentration to the higher concentration lower. But if you apply pressure on one side, that's ultrafiltration. For example, vessels are pressurized, So, another question.
Ma'am, actually we have forgotten the angle structures. Can you tell us how to remember the different angle structures?
Sir, there is one class of angle anatomy of angle, so somebody has prepared already.
Oh, okay.
He wants to know from you.
Nice answer. Good answer, teacher. Now you are sounding like a teacher.
Who has drawn those pictures?
Time
Who has
start
drawn
कर
those
देना, है ना?
pictures?
ठीक
The
है.
pictures you have shown.
Sir, yes, ma'am,
Oh,
on
good,
iPad.
Good homework. Teacher has done a better homework.
Good. That means you have received 1 month before.
No, I was just wondering if you could tell us the mnemonics for this angle closure. That's what I was looking for actually.
Sir,
Mnemonics. A, B, C, D, E.
yes, sir. Yes, sir. Sir, root of iris and ciliary body band. I can see it. Yes.
Okay. No.
This is the mnemonic.
All the teachers don't believe in mnemonics.
There is a mnemonic for
I can see
angle
this one.
structures.
सर आप बता दीजिए कि उसको इतना ग्राइंड कर रहे
छोड़ो
हो.
यार.
आ गया उसको याद आ गया. Now you can tell.
नहीं सर बता दीजिए, बाकी स्टूडेंट को यूजफुल हो जाएगा.
I for iris, then C for ciliary body band, then Schwalbe's line, then
Scleral spur.
then
Ciliary body part.
Trabecular
Schwalbe's line, trabecular meshwork, scleral spur.
निमोनिक क्या है? निमोनिक शॉर्ट फॉर्म
yes, sir.
आई कैन सी. ओके, आई कैन सी. चलो ठीक है, नेक्स्ट क्लास. ठीक है, आ जाओ. हो गया. ओके, थैंक यू. नेक्स्ट.
A very good afternoon, students. Today, I am going to present RD chart. Coming to the contents, today we'll discuss a bit of introduction, history of RD charting, Amsler-Dubois chart, how to chart, and color coding. Introduction: a standardized clock-hour-based schematic of the retina that accurately documents the location, extent, and configuration of retinal detachment and associated breaks using universally accepted color codes. Why it matters? It enhances communication, enables surgical precision, and creates a legal and clinical record. Before standardization, it led to non-uniform drawings and increased risk of miscommunication. Coming to the history of retinal detachment charting, Charles L. Schiffens, who is the father of modern retinal surgery, in 1945 developed indirect ophthalmoscope with standardized RD charting with clock hour notation and color coding and symbols. By 1950s to 60s, it led to global adoption of Schiffen's charting system throughout the world. Even today, in the era of digital charting and EMR systems, still use Schiffen's original clock hour method and color code conventions. Amsler-Dubois chart is represented by three circles: the innermost equator, the middle ora serrata, and the outer junction of pars plana and pars pliccata. It is divided into 12 clock hours. And how to chart. Examiner stands at the patient's head end at 12 o'clock position and patient lies supine. The image is a real, inverted and laterally reversed. And we examine 360 degrees in a clock hour sequence. And how to chart. You just need to invert the chart and place the 12 o'clock mark facing the foot end of the patient, and you just draw what you see. And then you turn the chart with 12 o'clock mark facing superiorly, and then label the chart accordingly. Coming to the color coding, the retina is principally represented by red and blue colors. The red represents attached retina, vascular structures, bleeding, live and viable structures, and blue represents detached or elevated retina and not in contact with RPE. The green represents vitreous and treatment, the yellow represents lipid, edema and deposits. The brown represents uvea, and the black represents pigmentation and scars. Coming to solid, it means fixed, definite and fully present, and crossline represents thin, transparent and partial. The stipple represents granular and multiple. Interrupted line represents not fixed and changes with time or posture. The red solid represents hemorrhages, open interiors of retinal breaks and holes in retinoschisis and vascular structures. The red crossline represents partially perfused structures like the open portion of the giant tears. And blue represents folds, outlines of breaks, neovascularization, thin areas of retina and lattice degenerations, and also elevations like cysts, tufts, tracts, cystoid degeneration and so on. Also it represents shifting fluid and separation like detached retina. And green represents all the vitreous structure and NFL defects. Yellow represents deposits, drusen, edema and exudates. Brown represents all the uveal structures and black beneath the detached retina. Black represents pigment, anatomical outlines, sheathing, scars and treatment like the cryotherapy. Relevance, the full peripheral view can be covered in dynamic and real time and useful in difficult cases with immediate decisions, portable and cost effective. And surgical relevance in planning the surgery. These are my references. Thank you. You can scan to avail my presentation.
Thank you so much. The next team, you can stay here. Judges will be asking questions to you. So meanwhile, I would like to invite team AIMS Bhopal. You are right. Okay. So next is team AIMS Bhubaneswar.
How do you see superotemporal area, like where you will be standing and where the patient will be looking, if you want to see the superotemporal area?
We will be standing at the 12 o'clock position only, ma'am, and we'll ask the patient to look superior temporally only. Inferior nasal, we ask the patient to superior temporally, we ask the patient to look superior temporally only, and then we see through the indirect ophthalmoscope. But while representing, we'll just draw where we saw the lesion.
You have drawn that.
You confuse the students.
Students are already confused.
This is a very senior student. Yeah, you can assign them the homework. Next class,
You've drawn
please
the diagrams yours?
read and come prepared.
Oh, that's great. Nice diagrams.
All of you are making so much effort. I think that is the beauty of this Teachers of Tomorrow session. Which lecture you are taking? AIMS Bhubaneswar. उनको बोलो ना तुम क्यों बोल रहे हो? तुम्हारा क्या टॉपिक है?
Ptosis. Evaluation of ptosis.
Ptosis है देखो.
Tilak, name Tilak.
I think you go and check there. Go and check. If not, Dr. Maurya sir, आपका केस है? Other one, okay. Actually, you are presenting the different topic. Okay, fine. So meanwhile, what is the meaning of your name? You got a very beautiful name. Rama, Tulasi, Sri.
Yes, ma'am.
Siri means? Gold and money, okay. You have Ram, Tulsi and gold and money. Good.
Palasi, Sri, Dudupuri.
Management of fresh retinal detachment.
Good afternoon, class. Today we'll be discussing the management of a fresh retinal detachment. So, retinal detachment is the separation of neurosensory retina from the underlying pigment epithelium. It can be due to a retinal tear, like in a rhegmatogenous retinal detachment, or it can be due to a vitreous traction band pulling neurosensory retina, like in a tractional RD, or it can be due to accumulation of fluid in the subretinal space due to a mass lesion or inflammatory mediators like in a exudative RD. And surgical management is usually indicated only in case of a rhegmatogenous or tractional detachment. And by fresh RD, I here mean only rhegmatogenous RD because usually exudative and tractional RD happen over a long time. So our management will start with careful retinal examination to find all the retinal breaks, remove any traction on the retina and create adhesions between the detached retina and underlying pigment epithelium. First by creating chorioretinal inflammation, sealing the breaks and ensuring chorioretinal apposition till the scar formation happens with an optional drainage of subretinal fluid. So preoperatively, we do an indirect ophthalmoscopy with scleral depression or an ultra-wide field imaging to identify all the breaks, and we do the same intraoperatively with an indirect ophthalmoscopy if we are doing a scleral buckle or with a microscope if we are doing a PPV. And link-off rules help in identification of the location of primary tear in case of a rhegmatogenous RD based on the SRF distribution. So for forming chorioretinal adhesions, we either freeze the healthy retina surrounding the breaks or apply laser to the healthy retina surrounding breaks to lead to scar formation. And to ensure the chorioretinal apposition, we provide tamponade either internally with intraocular gas, and the commonly used ones are SF6 and C3F8, which cause apposition of superiorly detached retina. And silicone oil can be used in case of giant tears or if there is extensive PVR. And external tamponade can be done with scleral bucklings where we use silicone explants, which can be tires or bands or sponges to reattach the retina. And SRF drainage is optional and it can be done by internal retinotomy if you are doing a PPV or external sclerotomy if you are doing a scleral buckling. Coming to the choice of surgery, in a cooperative patient who has superiorly located single break and no changes of proliferation, we can go for a pneumatic retinopexy, while a young phakic patient with anteriorly located break is an ideal candidate for scleral buckle. In a patient with wide bullous RD and marked traction and tears in multiple quadrants, we can go for a pars plana vitrectomy. For pneumatic retinopexy, the retinopexy can be done by cryotherapy or by laser photocoagulation, and paracentesis is done before gas injection. And after injection, we ask the patient to maintain a particular head position so that the break is in the superiormost position. Here we see a patient with superior RD treated with pneumatic retinopexy with attached retina 3 weeks postoperatively. And scleral buckle, we do a conjunctival peritomy and we give bridle sutures for all the recti muscles. And intraoperatively, we do an indirect ophthalmoscopy, identify all the breaks and apply cryotherapy for them. Then we give partial thickness scleral sutures for fixing the buccal elements. After which we do a external sclerotomy for SRF drainage. Then we adjust the scleral sutures for optimal buckling effects. And this is a patient treated with scleral buckling showing attached retina postoperatively. And pars plana vitrectomy, after putting the pars plana ports, we start with a core vitrectomy followed by peripheral vitrectomy. Then drainage of subretinal fluid can be done by fluid air exchange, following which after the retina is reopposed, endophotocoagulation is done to seal the breaks, and postoperatively we can give a gas or silicone oil tamponade. I hope you guys understood something. Thank you.
Good one. And next team, please be ready with your PPT on this side.
So if you have done a vitrectomy with a gas for a patient who has come from, say, Canada, because Punjab mein there are so many people coming. So what will you advise him? So how long will you tell them to stop? Not 5 days should be enough.
Na team.
And why?
Morias blaster. Huh?
If we are injecting SF6, it takes around 2 to 3 weeks to get absorbed. And if we are giving C3
Answer in the mic, so that other students can
Around
also
6
learn.
weeks it will take to be completely absorbed. But for maintaining the position, usually we ask them to maintain the particular position for 5 days. So at least for 2, if you are giving intraocular gas in high amplitude because the pressure will be low.
So what will happen to the gas? The point is, would you advise travel or not? Air travel.
Why
if
are you
putting gas?
stopping them to travel by air?
It expands in low pressure if we are going to higher altitude, and it will increase the intraocular pressure.
Yes,
Thank you.
good.
What happened to
So
the
next
packets of
speaker.
chips there? See packets of chips here. We go to late.
Thank you.
You start from there, okay.
Tilak is presenting, no? The other
What's
person.
her name? What's her name?
Shri.
Nice names actually.
Mahima, last 15 number, पीछे वाले page पे.
Yes, you can start.
Arvind Moyer.
महिमा क्वेश्चन.
अभी जो करते हुए
Now that I have your attention, did you really think that since we are in Amritsar, Punjab, we're just going to jam to this hit song by Diljit? Well, sorry to disappoint you, but we're actually going to talk about Hess chart. It's not moving. Yeah, thank you. So what's the history of Hess chart? It was devised by a Swiss physiologist named Walter Rudolf Hess in 1908, who even got a Nobel Prize for the same in 1949 for using it to map areas of the brain. Attention, this could be asked in the next quiz. So, the principle is based on haploscopic dissociation of the two eyes using red and green colors, and Herring plus Sherrington's law of innovations. Don't be fooled by this innocent-looking list of equipments. The Hess chart isn't just a plain old chart. It's basically an electronic board studded with tiny red bulbs. What you see in front of you here is just the version we use for interpretation. That and a pair of red-green glasses and lasers. So now I'll call upon Dr. Megha, my co-mentee, to help us understand the method of performing this test. It is done for each eye one at a time from a distance of 50 centimeters. Green color goes in front of the eye which is to be tested. The examiner shows red lights on the board and the patient has to superimpose green laser over red, while examiner notes down the result somewhat like this. Of course, we need full cooperation from the patient. It's a completely subjective test. So, if you've got an 80-year-old baby who keeps fiddling with her hearing aid, or an ADHD kid who thinks the red lights are DJ lights and starts a rave, well, good luck with that. The vision also needs to be decent enough and normal retinal correspondence is needed. For interpretation, we look at 3 things: size, position, and shape. A compressed size will be the case of an underacting muscle. A smaller field will belong to a paratic muscle. When we look at both the eyes, similar and dissimilar sizes and shapes suggest comitant and incomitant squint, respectively. The central dot tells us about the primary position of the eye. The central dot can be hyper, hypo, exo, or iso. Question is, how much? Well, each square accounts for 5 degrees. So, by counting the number of squares, we get that answer. As for shape, we get sloping fields, so we could be dealing with an A or V pattern squint. Therefore, we use Hess chart to identify which muscle is under or overacting, quantify how much is the deviation of the eye, differentiate between recent or a long-standing strabismus, and restrictive or paralytic strabismus. So let's go over a few examples. Which eye do you think is affected here? And what's the primary position? Correct. Right eye, you can see it in down and out position. Any bells ringing? Down and out? Exactly. Third nerve palsy. Now in this case, left eye is affected, but in which cases? Up and down, isn't it? So it can't be paralytic. Must be restrictive. Could be an orbital floor fracture. In this case, right eye lateral rectus is underacting with overaction of the left eye medial rectus. Diagnosis: right eye lateral rectus palsy. Too easy, right? Let's make it interesting. Is it recent or long-standing? Well, do you see any long-standing sequelae? No, right? So it's a recent onset. So that's all for today's lesson on HES chart. Now we can go back and jam to Diljit Dosanjh all we want. Thank you.
Thank you so much.
Nice.
And meanwhile, the judges ask question. I request Team Visionaries, your second presenter, please be ready there.
So how often will you repeat HES chart?
As long as the patient is still symptomatic and we can clinically see the manifestation.
Minimum
of squint
time
there.
and maximum time.
That's a very good question. I'll get back to you with that in the next
thank
class.
you.
Thank you, teacher.
Thanks.
What's your topic? Please tell them.
Acute management.
Acute?
Optic neuritis. Management of acute optic neuritis.
Optic neuritis.
Good.
So you are
Start.
Pallavi.
Good
Now come
afternoon,
the
everyone.
Pallavi. Huh?
now comes the tough task for the students. They have to go through again another round of 9 teachers. Yes, start please.
Good afternoon, everyone. So, topic for today is management of optic neuritis, acute. So, I'm assuming that everyone knows what optic neuritis is, but let's recap, okay? So, optic neuritis is the inflammation of the optic nerve, usually seen in young females and commonly associated with demyelinating disorders such as multiple sclerosis, which is the most common association. Others are NMOSD, MOGAD. Other than this, it can also be caused due to infection, inflammation, toxins, neoplastic, idiopathic reasons, lot of things, right? So first, if a patient comes to you with unilateral decrease of vision with painful eye movements, but a normal fundus, well, most likely it could be typical optic neuritis. Similarly, patient coming to you with bilateral vision loss may or may not be associated with pain, but there are fundus changes. Think of atypical type of optic neuritis. It's very important to know the difference between the two because there is typically a better recovery in typical kind of optic neuritis. So, apart from this, ocular investigations like visual fields are very important. They usually have a central or centrocecal scotoma. VEP will show a prolonged P latency, and OCT done after 3 to 4 weeks shows thinning of the peripapillary RNFL. Apart from this, for MS, that we can use CSF analysis for diagnosing based on oligoclonal bands. But for atypical, there are a lot of panel of treatment and lot of investigations required, like aquaporin 4 for NMOSD and MOG antibodies for MOGAD. So infectious workup can also be done depending on your clinical picture and your differential diagnosis. Imaging is very important. MRI with brain on orbit and with gadolinium contrast will show optic nerve enhancement, which is short and in patches in cases of MS with Dawson fingers, which are periventricular demyelinating plaques. In case of atypical, there will be bilateral involvement and the longer segment of optic nerve will be involved. So coming to treatment, which was mainly given to us by the optic neuritis treatment trial, which had 457 patients, which were divided into 3 groups. So the first group received IV methylprednisolone of 1 gram in divided doses for 3 days, followed by oral prednisolone for 11 days. Second group received only oral. Third group received placebo. So what happened after 1 year? What they saw was the 3 groups, everyone had the same visual function. So what's the use? Well, IVMP is causing faster recovery and also it decreases the development of MS, whereas oral is causing a recurrence, which is very, hence it is advised never to start patient directly on oral and always start on IVMP first. Apart from this, there are CHAMP study, which help in severe cases of multiple sclerosis, and it tells us that interferon can decrease the development of MS. Other newer drugs are also available, but let's go to an atypical type, where initially, even though you start an IV methylprednisolone, there is poor response. So in such case, you go ahead with plasmapheresis. After this, when you switch over to steroids, you also give them some immunomodulators like azathioprine or methotrexate. And after 4 months, if the adequate response is not sought, then other alternatives and second-line immunotherapies are given. A similar algorithm is is also used in MOGA diseases, but you have to make sure that when you're tapering the oral steroids, it's taper over a longer duration. So to summarize, optic neuritis, though a ocular finding, could be a very significant pointer towards a systemic disorder like MS. So prompt identification and treatment is very important. And remember, for treatment, IVMP, IVMP, IVMP. Thank you.
Thank you, Dr. Krati Gupta. Please come here for your next one.
What is the dose of IVMP and how do you give it and how long you have to give?
Ma'am, 1 gram is given. So in the trial, they had given it in divided doses, but we can give as a continuous one pulse therapy of 1 gram also for 3 days. And then after that, you have to taper it with oral steroids of 1 milligram per kg per day.
How do you give that? 1 gram, how do you give that? What is the duration and what you have to observe?
It's a slow infusion, and before that you have to definitely make sure that patient does not have any other systemic infectious pathology going on. So we do ask for medicine consultation. If patient has systemic infections, then we have to supplement it with antibiotics and accordingly. And
what do you observe when you give IV methylprednisolone? Suppose you are a doctor and you are prescribing and you have to tell Sister Aarti, somebody who is giving the IV methylprednisolone, what they should observe and that IV should go for how long?
How many hours? How many minutes?
Over how much time the IV should be? The bottle should be over. 30 minutes,
How much
45
fluid
minutes,
you
1
will
hour.
dissolve it into and how long it will take to go?
Dextrose or normal saline, 500 ml or 1 liter.
100 ml.
So it should ideally be given over 1 hour. So you are giving
1 hour is fine. 1 hour is okay.
30 to 45 minutes you can choose. It's okay. Next class we'll discuss this. Okay? We are running short of time.
We are short of time.
Yes.
Okay.
आप लोग बैठोगे तो चलो पूछो.
चलो ठीक है. Leave it.
That's what we expected from optic neuritis.
So said I'll get back to you.
What's that?
Start.
Okay. Oh, some surprise for judges.
EVT, PPT दो.
Good afternoon, class. I know it's post-lunch and none of us want to have a lecture. So we are going to start with the game, okay? UCMS Mavericks present the binocular game. We are going to start with the game. So first we have to choose a character, right? So we have Dr. Pragya and we have Mr. Mario. We being the best ophthalmologists here, of course we'll choose a doctor to play the binocular game. Before starting the game, we need to choose our level. I am going to go with the 2D level because I think it's easy. To proceed, I would like 2 of you people to please patch one of your eyes. Ma'am, if you could please patch one of your eyes.
How is his score if you patch her eyes?
No,
So
I
one
will
of the
score
eye.
half only. If you want that, I will be here, but then I will score half only.
Now I would want ma'am to touch the tips of both the pens. And I would like sir to, as you can see, in the 2D world, you won't be able to touch the tips of both the pen. This is called as the Lang 2 pencil test, which is one of the tests of stereopsis. In order to move forward, I would like ma'am to remove the patch and enter into the dimension of stereopsis. Welcome to the dimension of stereopsis. What is stereopsis? It is the 3D perception of an object which occurs when the object is present in 2 different angles, which is viewed by both the eyes. So there are many tests that can be used for stereopsis. One such test was demonstrated by ma'am. Using both eyes also, she demonstrated the test. The other test includes the very famous fly. So let's get into the titmus stereo test. Wear your polarized glasses and enter into the test. There are 3 types. There are 3 sections of the test. The first is the fly, which is the polarized vectographs, which is for gross stereopsis and has a threshold of 3000 seconds of an hour and are useful for young children, and even adults can enjoy touching the wings of the fly. The other section involves animals, which has 3 rows of animals with 5 animals in it. Each row has a threshold of its own with increasing difficulty, and it even has misleading clues which will make the level to cross more difficult. The third section involves 9 squares with 4 circles each. One of the circle in each square is dissimilar image at a random threshold ranging from 800 to 40 seconds of an hour. The circle 5 is equivalent to 100 seconds of an hour. If you can do that, you can go forward. The other test includes frisbee test, which does not require any glasses. There are 3 plates of about 6 centimeter, 3 centimeter and 1.5 centimeter thickness, and the disparity is because of the displacement that is happening because of the thickness of the plate. Then we go to the Netherlands organization, which is the TNO test. It requires red and green glasses, contains of 7 plates. 3 of them are used to establish gross stereopsis, while the other 3 are used to establish better measurements of stereopsis. The next test is Lang test, which consists of random dot stereogram. This does not have any monoocular clues, so it is better. There are no glasses needed. Lang 1 is for gross stereopsis, while Lang 2 is for finer measurements. It has a star, a cat, a car, and an elephant. Now, in order to cross the level, we need a mnemonic or a cheat code. So this is the mnemonic that I have come up with. 2 turtles ran fast like lightning. So all these tests can be summarized into this mnemonics. And finally, after using the cheat code, we have a winner in the 3D world. Thank you.
Wow.
Good one.
Thank you, teacher.
Any questions by the judges?
What are the monocular clues to the depth perception?
Dr. Saloni Goel, you please ready with your PPT.
So the distance at which the objects are present, or the angle at which they are present, or the size of the objects. These can be the monocular clues that can tell the size of the objects that are present. That can tell us whether the object is closer to us or farther away.
Anything else?
So the angle at which it is viewed.
Have you seen the railway lines? What do they look like?
So
Railway
they
track.
cross.
Okay. Have you seen ma'am is sitting in front of her? What is that? Have you seen the granularity? What is, if you can see the texture of his face and somebody? They're all monocular clues. So that is why even the one-eyed people, they can detect the, which object is near, which is distant. Yeah, absolutely. Play with the one eye, yes. So these are monocular clues. That's why one-eyed people, get used to these monocular clues and they can go around the world very well. A lot of them drive too.
Thank you. So we have Dr. Saloni from team Glocostars, right? Yes. After Saloni, please, Dr. Shankar, you please be ready.
Yeah, I'll be presenting on the topic of management of congenital dacryocystitis. Just a brief, it is what? It is a membranous obstruction that is present at below the NLD. Imagining this is the nasolacrimal duct. There is a membranous block over here at the valve of Hassner. So the child presents with watering, discharge, matted eyes. We know there will be regurgitation of pressure will be positive, and there will be delay in the disappearance of the dye. So what is the management? Most of the cases resolve spontaneously early in the infancy. If they don't, we have various management options which I'll be discussing one by one. First of all is the conservative management, in which we are not doing anything invasive. What we have to just do, we have to do a massage of the lacrimal sac area, which is known as the Kriegler's massage. What we do, we take the index finger, we teach this to the mother. No role of the kid over here. Kid is small. We teach this to the mother. Take the index finger, press over here near the below the medial canthal tendon and move inferiorly. What this does is that it creates a hydrostatic pressure in the duct, which causes the opening of the duct, which was closed below. This is the image of the blockage getting resolved and the direction of the massage. This is done in a child who is less than 1 year of age. We prescribe this, and it is done as 10 strokes 4 times a day. Various studies have demonstrated a good efficacy rate of around 91%. What is the benefit of this? No side effects, can be done at home, non-invasive, and a good compliance. This is the direction. Antibiotics can be added if there is a mucopurulent discharge present. The second is the probing of the nasolacrimal duct. What we do in probing, the indications are if the conservative management fails, if there is severe infection or recurrent infection. What we're doing with the probing is that we are puncturing the obstruction which was present there at the nasolacrimal duct below that. So there are various controversies whether we have to do early probing or late probing. Early can be done if we want to operate the child for any intraocular surgery, like for any congenital glaucoma or any congenital cataract, or if the child is very symptomatic. What is the advantage of that early is that we are causing less risk for cellulitis. But what is the disadvantage? Because 2/3 of the cases can spontaneously resolve, we are putting the child for an unnecessary intervention. So there was a landmark study which showed spontaneous resolution. After 12 months, there is very minimal resolution. So late probing was advised. What we can do it as OPD procedure or as a OT procedure with various types of anesthesia, and there are various probe size. Imagine this as the probe, as the Bowman's probe. First we'll dilate the punctum with the punctum dilator, then we take the Bowman's probe, engage it in the punctum, and then we just stretch the eyelid a bit horizontally. We put the probe, and then the probe is moved vertically down into the nasolacrimal duct. And then what it does is it punctures the membrane that was below down there. How to know it is in a correct position? There will be aligned with the trochlea, and we confirm the patency with syringing. There can be certain problems with probing, like false passage or an obstruction. Obstruction due to turbina can be controlled by inferior turbinate in fracture. Probing can be repeated for 2 to 3 times, and there is a good resolution rate. Then there is intubation of the nasolacrimal system. Intubation is done if there is failed probing. What we do in intubation, we put a stent. We have various types of stent, monocanalicular and bicanalicular stents. What we are doing in a stent is that we put one end of the stent through the punctum, and we pull it out using a hook. There's a hook that comes with the Crawford stent. We pull it out into the cavity. And then we take the another end, we put it into the punctum, and we again pull it out. And then near the inferior turbina, we tie these two ends together in a knot so that it does not slip away, it retains. What it does, it creates a passage. There is no obstruction with that. This is the tying, and this is the endoscopic view. There can be another, that is a balloon catheter dilatation. There are 2 types of balloons. Anything that is compressed, we go over there, we inflate it, that opens. There are 2 cycles of inflation, deflation, and the probe is then it is confirmed with the saline. The success rate is almost comparable to the intubation and with the probing. We have another option, that is a DCR, pediatric DCR. In cases of if everything fails, what we are doing is, if there is a roadblock, what we do? We take a bypass road. So we are taking another road over here. We make another opening in which the tears flow through the nose into the pharynx. A good success rate, and all these can be combined with endoscopy for better visualization and a good success rate. Thank you.
Thank you so much. Next is Dr. Shankar Narayan from...
Yes, sir. Sir, if the child is less than 1 year, there have been reports that we can do under mild sedation as an OPD procedure, or we can do it with the restraint also. If the child is more than 1 year, it is preferable to go for GA because it gives a good view also, it gives a good time also to assess the things. Because less than 1 year, we don't want to put the child for GA complications.
And this DCR, at what age?
Probably, sir, after 6 years of age, most of the studies have recommended.
Thank you.
Thank you. So after Shankar, it's Nivedita. Please be ready.
Thank you, doctor.
PPT,
Guys, am I audible? Yes. Yes. Thank you, sir. Then my topic for today's class will be fundus fluorescent angiography. Coming to the introduction scope, the technique of fundus fluorescent angiography is mainly used to assess the the vascular structure of the retina and the choroid using a dye which has a fluorescent property called as fluorescein, and this is used to identify the vascular pathology and assessment of the vascularity of the retina. Now we'll be seeing about the physiology and also some imaging and some of the clinical decisions that we can take using FFA. So coming to the principle, it is based on the principle called as fluorescence. We have a dye called, the hero is the dye, that is the fluorescein, which has a property of fluorescence. which is nothing but when we excite the dye, the particles absorb the light and go to the higher energy state, and while coming back, the extra energy is emitted as a different light. So excitation light will be, in case of fluorescent dye, will be blue, that is which belongs to which is around 465 to 490 nanometers, and the emission will be in yellow green spectrum, that is 520 to 530 nanometers. The fluorescent property, barrier and excitation filters play a very important role, and it is also used for choroidal and retinal circulation differentiations. Coming to the pharmacokinetics of fluorescent dye, it is highly plasma bound. That is how we can visualize the retinal vasculature, and the distribution of the dye happens between vascular and extracellular compartments in the retina. The peak ocular circulation occurs in 7 to 15 seconds, and it is excreted by renal system, and the half-life of dye is about 23 minutes. The excretion makes the urine turn bright yellow. So coming to the technique and equipment, it is used, main instruments that are used are fundus camera, then wide field and ultra wide field system to visualize, and data storage and image analysis systems. And coming to detailed phases, we have 6 phases. That is choroidal flush, that takes place in the first 10 to 12 seconds, and arterial phase, arteriovenous or capillary phase, venous phase, late venous phase, and recirculation phase. Coming, there are mainly three patterns, that is hyperfluorescence. In hyperfluorescence, we have leakage, staining, pooling, window defect, and autofluorescence. And in case of hypofluorescence pattern, we have block fluorescence, filling defect, delayed choroidal filling, capillary dropout, hypoperfusion, and we can, by correlating, we can take decisions based for the diseases. So coming to the role of FFA in diabetic retinopathy is identification of neovascularization, differentiating between neovascularization and IRMAS. So there are other retinal vascular lesions like CRVO, BRVO, and arterial occlusions that we can identify using FFA, and also macular and choroidal disorders like CSCR, in which FFA plays a crucial role. We have certain artifacts which can be there, and I have a short quiz. If some of the students can identify this.
Quiz
It depends on. It decides your attendance today. Yes, sorry. Yes. Sir. So this is an artifact which is called as crescent, yellow crescent, which occurs due to improper access between the camera image capturing and the patient, and this is due to bright flashlight that happens. Yes, thank you.
Thank you, Shankar. That was a wonderful lecture. Yes, any questions?
A couple of questions. Yeah. What quantity and what percentage of the dye will we use?
Sir, there are 3 concentrations that is more commonly used. If it is 25%, we use 3 ml, and if it is 10%, we use 5 ml, and if it is 5%, we use 10 ml of the
20%, 3 ml.
25%.
20%.
20%.
And can we use a dye to drink and do a angiography?
Sir,
or it is only by intravenous use?
Sir, intravenous will be better, sir, because the absorption will be better. Oral.
There are mechanisms of oral fluorescence also.
What is the preparation you require? Is there any side effect? Is there any emergency?
Yes, ma'am. The higher the concentration, because it is iodine based, there is always history of allergy, and the most common is vomiting. Sorry, vomiting, nausea.
Iodine based.
Iodine based. Oh, sorry. Fluorescence. And vomiting, nausea, hitch, and it is prevented. It is preferred. It is avoided in renal, chronic renal disease patients. So 5%, 10%, 5 ml. 10% 5 ml is the most commonly used. Yes, we are using 10% and 5 ml.
अखंड ज्योति में क्या यूज होता है बताइए?
10% of 5 ml of fluorescence. Yes, fine.
ठीक है, thank you teacher.
20% 3 ml is what we normally use, but that's fine.
It's okay.
Absolutely
Start.
fine.
Dr. Nivedita.
Good evening, everyone. I'll be discussing about the management of central serous chorioretinopathy, which is nothing but the localized serous detachment due to accumulation of SRF. Due to accumulation of SRF between the neurosensory layers and the retinal pigment epithelium, and it has predilection for the male sex in the ratio of 6:1. It will be absurd discussing management of a disease without knowing its pathology. It mainly constitutes of three portions, which is namely the choroidal hyperpermeability, the retinal pigment epithelium dysfunction and atrophy, and serous retinal detachments. There are major risk factors like corticosteroid usage and systemic inflammation which predispose to this condition. So the diagnosis can be clinical, which is most common, and the multimodal imaging can be done in the case of chronic CSCR and in the cases where the disease is non-resolving. So as we all know, clinically the patient presents with the unilateral blurred vision, micropsia, metamorphopsia, and retinal relative scotoma, and signs we can see on the fundoscopy. There is round to oval sensory detachment with subretinal deposits. Multimodal imaging can be done in the cases of chronic CSCR and non-resolving CSCR patients. So on fundus fluorescein angiography can help us to differentiate between acute and the chronic cases. In acute cases, in an early phase we have a pinpoint hyperfluorescence, and in mid phases we can have the characteristic ink blot and smokestack patterns. In chronic cases we can have patchy, granular, and mottled appearances of hyperfluorescence. Endocyanin green angiography is gold standard in the cases of choroidal pathologies. In mid phase we'll have indistinct hyperfluorescence. Optical coherence tomography can help us understand the pathophysiology of the disease, as we can localize the regions of pigment epithelial detachment and the retina complications like choroidal neovascular membrane, and also prognostic indicators like photoreceptor elongation, hyperreflective dots, and ellipsoid zone disruptions. Fundus autofluorescence can also be done, which can differentiate the cases of acute and chronic CR. In cases of acute CR, there is SRF masking due to hyperfluorescence due to the SRF masking, and in chronic cases, we can have patchy and granular hyperfluorescence due to accumulation of lipofuscin in the retinal pigment, in the photoreceptor outer segments. And in chronic cases, we can have gravitational tracts. Classification of CSR, now it has been proposed that multimodal imaging should be used to differentiate it in the cases of simple, complex, and atypical cases in order to ease the management. So treatment remains, we have to stop the risk factors, we have to wait for 3 to 4 months as 90 to 95% of cases resolved during this period, and then we have to go about the treatment of the disease. So most common indicator risk factors, as we have already discussed, it remains the systemic inflammation, corticosteroid use, smoking, and stress. And then we go about treating the disease if the disease is not resolving. We can go for photodynamic therapy. In this we use vertiporphin, which is a photosensitizer, and we apply laser at 689 nanometers for 83 seconds, and it causes restructuring of the choriocapillaries. There have been trials like SPECTRA trial and PLACE trial, which have compared its efficacy with eplerenone and subthreshold micropulse laser. In both the cases, PDT was found superior. We can also go for focal laser treatments in cases of extrafoveal leaks, and rarely used within 500 micron of the fovea, and it causes thermal induced burns, thus sealing the RP leaks. Subthreshold laser, now it has been recommended by the Subthreshold Laser Society to be used within, can be used even within 1 month rather than waiting for 3 to 4 months. In this we give short pulses of 5% duty cycle, 200 milliseconds, and spot size of around 200 microns with no spacing in between. So there is no standardization limits. And there have been trials like PECORIS trial and PLACE trial. In PECORIS trial, its efficacy was compared with spironolactone, and the resolution was found better with the subthreshold micropulse laser. In case of PLACE trial, it was compared with the half-dose PDT, and PDT was found superior to it. There are certain oral medications, as we have seen that corticosteroids have a role in this. So in this trial, the mineralocorticoid receptor antagonists like spironolactone or eplerenone can be given in the dosages of 25 mg BD or 50 mg OD. So the VC study showed that in contrast to the placebo, it was no better in terms of the best corrected visual acuity. In SPECTRA trial, it compared it with half-dose PDT, and PDT was found superior to it. Other medications include carbonic anhydrase inhibitors and melatonin. So in both the cases, it helps by increasing the RP transport. There is rifampicin, which induces cytochrome P450, induced metabolism of corticosteroids. There is aspirin, as it reduces thrombosis, which is also a risk factor for presentation of CSR. Anti-VEGF therapy has a limited role in this because, and it can be used in the cases of complications like choroidal neovascular membrane formation. Thank you.
Thank you. Next teacher is Suprit Kaur.
No, sir.
Idea?
Novartis guys used to have it, but now they have discontinued the drug.
Why do we have smokestack sign?
Yes, sir.
Why do we have smokestack sign?
So, incidents?
You see, have a smokestack sign in this one? Yes.
Yes, sir.
Why do we have it?
So, because of the detachment, the fluid that gets accumulated.
Hey, why do we have smokestack?
Yes, sir. So, due to the leak, focal RP,
लीक
there is
तो
break.
होता है बट smokestack क्यों होता है? ऐसे
Gravity.
जाता है क्या?
So,
वही होता है?
there are both the patterns, smokestack and inverse
नहीं मैं तो
smokestack.
पूछ रहा हूँ smokestack क्यों होता है?
Gravity.
Yes. What gravity? One word for gravity. Specific gravity होता है कुछ?
Yes, sir.
क्या होता है?
So, we compare gravity to the water.
चलो अगर आप उसको एब्सोल्यूट ग्रेड दिखाओगे तो जो सेंटर की लाइन है CSR में वो they'll be closer to each other or they'll be apart. If a patient has central CSR, you show him the absolute grade. उसकी जो लाइंस हैं तो दूर तो होंगी तो पास पास होंगी. तो ठीक है. ठीक है ओके. नहीं स्टूडेंट्स को नहीं पता था इसलिए पूछ.
After Supridit Murli Krishna, please be prepared.
Shall I start, sir? Good evening, everyone. So, Stelwag coined a term ectopia lentis in 1856, which meant the displacement of the natural crystalline lens. If the displacement of the lens is inside the patellar fossa itself, it is a subluxated lens. If it is outside the patellar fossa, it is a dislocated lens. The etiology can be inherited or acquired, most common being traumatic. The inherited forms include the isolated forms and also the ones associated with the systemic anomalies, most commonly Marfan's, homocystinuria, and Weilmar-Chesney syndrome. So this picture is of a simple ectopia lentis and another one is of ectopia lentis at pupillae. Presentation, there is a decreased distant visual acuity. Dramatic fluctuation of vision can be present due to phakia and aphakia, and progressive movement of lens can lead to hypermetropic or myopic shift in between. Poor near vision, monoocular diplopia, painful red eye, visual field defects and glare photophobia and other features. So a detailed history is very important. Specifically, we should rule out the skeletal problems, specifically the Marfan's, Weilmar-Chesney and homocystinuria, which are the common ones. Detailed ocular evaluation is also very important. Further, lens position should be evaluated. Also, the phacodonesis part should be evaluated by the surgeon beforehand. Degree of zonular loss should also be evaluated. And if there is inferior subluxation, it often indicates a 360-degree zonular insufficiency. That needs to be taken care of preoperatively. Conservatively, if the refractive error is stable, visual correction can be done with glasses, contact lenses. Also, the patient can be given cycloplegics or YAG iridectomy can be done. And surgical measures can be done if the lens is in the anterior chamber, it is causing uveitis, glaucoma, or any other issue. On minimal subluxation of clear lens, spectacle correction is the best we can do. And if it is marked, then it should be removed with via vitrectomy or phacofragmentome. If it is a cataractous subluxated lens and minimal, then phacoemulsification with intraocular lens is done. If it is marked, again then lensectomy with fragmentome or phacoemulsification with then scleral fixated IOL can be done. The surgical management of subluxated lens can depend on the clock hours of subluxation of the lens. Anteriorly dislocated lenses can be best treated with removal through limbal approach, and if it is posteriorly dislocated, it should be surgically removed with complete vitrectomy. The capsular tension ring size often depends on the axial length of the patient. This is an Ahmed capsular tension segment. The refractive management is utmost important. 2 refractions need to be done for the portion of the pupil which is covered with the crystalline lens and for the portion which is not covered. The medical management is very important if there is any associated systemic issue. Surgical treatment, as we have discussed before, is done in these cases. Low vision management can be done with high plus specs, aphakic contact lenses, near optical devices, telemicroscopes, magnifiers, electronic magnifying devices, non-optical aids, and sunglasses so the patient has reduced photophobia. So it's a hereditary condition, so appropriate genetic counseling is recommended. Most of the patients are syndromic, so co-management with other specialists is a must. Thank you so much, sir.
Thank you.
I just have one question.
Yes, sir.
What is the difference between dislocation and ectopialitis?
So dislocation is basically if it is out of the patellar fossa. So so dislocation, we say if it is outside the patellar fossa, it can be anterior dislocation in the anterior chamber, or it can go posteriorly in the posterior segment. And ectopial is basically, sir, it is also a dislocation. We can say it can be displacement and dislocation, sir.
In ectopial lentis, the
mixture
zonules are asymmetrical. On one side they are bigger,
They are
larger, and the other
smaller,
side
yes,
they are
sir.
smaller. Dislocation, the zonules are ruptured.
Okay, sir.
Although the zonules are there, but
they
they
are
are ruptured. They are equal in size all around 360 degree.
Okay.
So that is the difference between ectopia
Lentis and
dislocation.
dislocation. Okay,
And that is Marfan's homocysteine. There will be a ectopic patellar fossa.
yes, sir. Thank you, sir.
EV team PPT though.
Thank you so much, sir. Thank you, sir.
मुरली कृष्ण
EV team PPT though यार.
कृष्ण सो गुड इवनिंग सब लोग क्लास सुन के तक गए होंगे चाय भी पी रहे स्टूडेंट्स सो myself Dr. Murli Krishna. I'll be teaching with the management of acanthamotic keratitis. Before going to the management, a bit of introduction about acanthamia. They are the free living cyst forming protozoans which are ubiquitous in soil, air, soil, dust and water. Out of 11 species, Acanthamotic castellani and polyphagous are the most common causing the keratitis. Life cycle includes motile trophocytes and dormant cyst stage. And potential risk factors of acanthamotic keratitis is one is 90% those who wear the contact lens wears, and trauma and contaminated swimming pools. So clinical features includes severe pain more than the corneal findings. In early stoma, the most characteristic sign you find is the radial perineuritis, which is seen in this image. That is a granular infiltration along the corneal nerves. That is why the patient will have the severe pain. So in late stomal phase, you will see the whitish grayish influences seen in this image. So it is a ring form. In the central cornea, you will have this marked edema with anterior uveitis. So investigation includes corneal scraping, among them staining and culture. So these are the most common stains which are used in the hospitals. One is a 10% KO sweat mount and gram stain and ginger stain. So in this you can see the hexagonal double wall cyst seen, and then in gram stain you can see the pseudopodiatric projection of trophophylls. These are not routinely used papillonuclear stain and past stains. This is a corneal smear showing this blue arrow showing the cyst and the yellow arrow showing the trophocytes. And this is a sample taken from the contact lens showing the acanthamotic cyst past 10. So culture is done in the non-nutrient agar with overlying E. coli. You can see the typical track of trophocytes motile lens. So after repeated corneal scrapings, even though the investigation is getting negative, so we can go for the corneal biopsy. So in the same reason, corneal biopsy with the past stain and then calculable bite staining, you can see this amoebic cyst. So same thing is confocal microscopy is a non-invasive method. Same thing you can find the cyst with trophocytes. So coming to the treatment, so we have a bigonets, which is the first line of therapy. It includes polyhexamethylene guanine and chlorhexidine, which is a 0.02%. They act like a cationic surfactant with digital properties. So only drug with cyst, only drug effective both. We can remember as B as both. And diademis hexamethylene includes affects cell membrane perpetuity. It is D for D. You can remember as double the events. And triazoles includes it can be given as adjuvants. So preparation of 0.2% of PHMB is you can put take 0.1 ml of 20% PHMB and you can dilute with 100 ml NS. So imidazoles, itraconazole will be given as an adjuvant potential for trophocytes. So oriconazole efficacy in some recalcitrant cases and never as monotherapy you can, because it develops a resistance. Aminoglycans, neomycins can be used in assisting in vitro, although it is having some toxic effect in the corniculum, so minimal role in modern therapy. So role of steroids is very controversial. Improvements in clinical sense because of anti-inflammatory signs used in uveitis, cleitis, on. So however, treatment with acanthamoeba, dexamethasone hastens there and existence of resulting 10 to 4 times increase in the trophocytes. Surgical treatment, you can go for the epithelial dependent as a therapeutic if it is used in intraepithelial. Penetrating cateterism can be used. Indication for this is therapeutic resistant infection, severe stromal melting with retinal and pulpiment corneal abscess. So goals of medical therapy is eradication of a viable cyst and trophocytes and rapid resolution of associated inflammatory response. So summary is acanthamoeba is difficult to treat prolonged necrosis and are requiring anti-amoebic drugs. Common differential diagnosis is arbitic keratitis. Early diagnosis of acanthamoeba is crucial and effective treatment of acanthamoeba. Pain differential of clinical signs in early presentation, late presentation in patient may have painless. Inflammatory acanthamoeba pediatric characteristics may be indicated. References. Thank you.
Thank you. Next speaker, Raju.
Factor for acanthamoeba keratitis.
Tilak Raj,
One
right?
is the most important factor is contact lens failure. So 90% will get infected with this, those who were using some homemade solutions or contaminated water. Like these are one is other one is trauma.
Not gym.
Trauma. Other one you can
This is the tactics.
These are the
Don't
most
get
common
distracted.
factors.
Okay, thank you.
Okay, so we have next teacher, Dr. Tilak Raj from Team AIMS Bhubaneswar, right?
Good afternoon, class. Today I will be taking a brief lecture on evaluation of ptosis. So what is ptosis? Ptosis is nothing but the drooping of eyelids. First we know the normal position of eyelids, which is 1 to 2 mm below the superior limbus of the upper eyelid and lower eyelid just touching the inferior limbus. So let's say our droopy, not so happy patient come to OPD with this complaint. What are complaints you can come up with? Drooping of upper eyelids, small eyeball and diminution of vision. It is important to ask for age of onset and progression, associated symptoms such as alteration of jaw movement, double vision, limitation of ocular motility and difficulty in deglutition and diurnal variation, and history of trauma. In past history, it is important to ask for childhood amblyopia and spectacle usage, ill-fitting contact lens which can cause blepharospasm and eyelid trauma, and recurrent allergic conjunctivitis. In past medical history, diabetes mellitus history and hypertension history is important as they can cause ischemic palsy. Recurrent hordeolum chalazion which can cause mechanical ptosis, and neurological disorder and medication should be ruled out. Past surgical history of previous history of squint and ptosis surgery and history of peribulbar block usage. Any instrumental and forceps delivery can cause birth trauma to eyelid, and family history of BPS which can inherit as autosomal dominant and also sporadic. So before coming into conclusion of ptosis, pseudotosis has to be ruled out. So pseudotosis is a condition where LPS action and anatomy is preserved, but conditions such as lid retraction of the contralateral lid, inophthalmosis and dermatochalasis, blepharospasm, hypertropia can mimic ptosis. On examination, they have a typical posture of chin elevation and frontalis overaction with extraocular movement restriction and neurological and neuromyogenic ptosis, and cover-uncover test to be done to rule out pseudotosis and also double elevator palsy. And associated features such as previous trauma, mechanical causes, pupil reaction, and jaw muscle movement should be noted down by asking the patient to move the jaw opposite side to the ptosis, which improves the lid retraction of the ptotic side. MRD1 is the single most important measurement used to create the ptosis. MRD2 measures the lower eyelid retraction, and summation of these to give the vertical palpebral feature. MRD3 is the MRD1 in the extreme most of case. 62. Margin crease distance is measured by asking the patient to look down, and the distance is measured from the most prominent crease to the eyelash margin. High and prominent seen in aponeurotic ptosis, faint is seen in congenital ptosis. LPS function is assessed by pressing on frontalis, locking the frontalis, and ask the patient to look from lowermost case to uppermost case and assist. LPS function is assessed. Vertical tarsal height has importance in fascicular servant surgery, and phenylephrine test has importance in molar resection. Herring phenomenon is important if the patient is having bilateral ptosis. It's based on the principle of equal innervation, where the patient is informed should be informed regarding chances of other eye contralateral eye ptosis surgery in the future. Bell's phenomenon is performed by raising the upper eyelid and pressing and asking the patient to forcefully shut the eyelids. Other tests to programs to get the post-operative exposure into normal corneal bleeding test, Sharma test, fluorescence staining, tear breakup time, and fundus examination should be done in the relevant cases such as CPO with pigmented retinopathy. Cardiology consultation is very important as they can also have cardiac conduction defect. So some short cases in OPD. So first case we have down and out pupil, mydriasis, ptosis. What can be the diagnosis? So third now palsy. Second case improvement of ptosis after eye spectrum and positive fatigue test. It could be myasthenia gravis. Third, absent lid crease with prominent with increased intervertebral distance and lower gaze. That could be congenital ptosis. Fourth case is higher up and raised lid crease and good levator function middle to old age patient. That could be this is just upon ptosis. Based on the grading, surgery is the surgery is necessary. Thank you.
Thank you so much. And
So,
yeah.
at what age in congenital ptosis will you operate the child?
Team busters.
So it's important. I'm not sure about the exact age, but it's important so that they don't develop the sensory deprivation amblyopia. So it's preferred to do earlier. I'm not sure about the exact age. They can go for sensory deprivation amblyopia, so it's better to.
So if it is covering the pupil,
it should be generally earlier if it's covering the pupil.
And if it is not covering the pupil?
I'm not aware of the exact age.
Thank you.
Yes, you can start. No music this time.
Yes. Presenter.
गेहूं के खेतों में कंघी।
Okay. Yeah. Can we restart the timer? It's come now.
गेहूं के खेतों में कंघी जो करे हवाएं, रंग बिरंगी कितनी चुनरियां उड़ उड़ जाए।
It's not moving. If he can risk his cornea for a national award, we can at least sit up and listen to this class on fungal keratitis to treat him if he ever walks into our OPD. It affects the working population, our humble farmers with high morbidity. While antibiotics keep on evolving and we have a new one coming up every 5 years, natamycin has been our first line treatment since 1960s. While signs like pseudodendrites, satellite lesions, endothelial plaques with raised lesions, a thick hypopyon, immune ring, pigmentation are all signs which could hint towards a fungal keratitis, feathery margin is the one sign that would lead us to the diagnosis. As per Mudd trial, it is the most specific sign for fungal keratitis. Even the best of us can get puzzled when similar looking lesions plant themselves on our slit lamp. One of our tools is the confocal microscope, which can help pick a fungal element. So when we are stuck in dilemmas like Tani partner, always trust our good old corneal scraping. Scrape the leading edge and center on a slit lamp or under a microscope with care to not perforate. Maybe learn to check the slides on a KOH mount yourself with that cute microbiology resident and treat him later. These staining methods will confirm what we suspect. These thick bamboo-like elements is what fungal hyphae would look like on KOH mount. There's always a chance of finding coexisting bacterial and fungal elements on the KOH mount. These round or oval budding forms indicate yeast. However, when we have limited scraping, always choose to perform gram stain as it is far more sensitive for both bacterial and fungal elements. Some fancy stains like GMS and calcifluor can always help in case of a dilemma, while cultures help guide treatment. PCR should be reserved exclusively when there is a very small sample. Needs to be interpreted with care as it is very sensitive and artifacts can get amplified.
amplified. The medical management consists of topical, intrastromal, and oral antifungals. Polyenes like amphotericin, natamycin disrupt the cell membrane, while all azoles cause inhibition of production of cell membrane. The giant cosmic mud trial established the basis of using natamycin as the drug of choice for all fungal keratitis. And why not? Look at those ragged edges become subtler and more well defined. But even Sachin Tendulkar can get stumped at 2 runs. So can our natamycin by bowlers like diabetes, dacryocystitis, or contamination. Our next weapon is the intrastromal injection with voriconazole or amphotericin. However, we have no RCTs to prove their efficacy. Rather, intracameral is preferred. The only indication for adding oral antifungals is scleritis and endophthalmitis with careful LFT monitoring. However, MUD2 established no added benefit by adding oral voriconazole to topical agents. All these conclusions are today incorporated by topical systemic targeted therapy protocol. First line of defense continues to be natamycin with or without addition of oral antifungals in severe ulcers, addition of voriconazole as a second line of defense, and intrastromal and intracameral antifungals as third line of defense. And when all fails, TPK saves. So when do we pick the scalpel? When we are suspecting a perforation for a stubborn non-healing ulcer after ensuring adequate and appropriate treatment when there's threat to limbus or additional sequelae like secondary glaucoma. Our goal is very clear. Eliminate the infection, protect the integrity, and prevent sequelae. Start with measuring, refining the host cornea, separate the membrane from a lens if any, make a huge PI, aim for perfect, equally spaced radial sutures, neither too tight nor too loose, ensuring a well-formed AC. With your good karma, maybe you'll be lucky enough to end up with a clear graft after your TPK. But I'm here to tell my other students with their not so good karma that even if you end up with a failed graft, it's not on you. It's an expected outcome in TPK. Just as much as a clear graft is, which can get infected and again become a failed graft. In the end, I hope you go back home remembering that despite a million clues, microbiological confirmation is mandatory. Start with natamycin, escalate as appropriate, and have realistic goals of infection eradication from your TPK. Thank you.
Very nice.
Last but not the least.
Thank you so much. It's not the last, so we still have 2 more presentations. One team came late.
Is there any role of glue? Glue.
Glue. In case of TPK, you mean for TPK?
For fungal corneal keratitis.
That's a good question.
Thank you.
And I'm very proud of my students who've read up so well and stumped my teacher and stumped the teachers. North is more known to be as affected by fusarium, while the south is affected by aspergillum. But the drug of choice continues to be natamycin for all fungal keratitis.
What percentage of ulcers are expected to be fungal?
60, the load of fungal to bacterial is 60% in our country as opposed to the rest of the world where bacterial is a bigger issue.
How much? Equal or?
So last team is
the load of fungal is much
GG's
more
glare
than bacterial
busters,
in our country.
Yeah, start.
What percentage? Any study?
So 60%, that's what the
South Indian study where you finished.
the mud trial, sir. Mud trial.
Chalo, start.
A very good morning to my very sleepy audience. Let's talk proptosis. Let's talk about popping eyeballs. So what is proptosis? Abnormal anterior displacement of globe more than 21 mm is considered proptosis, or more than 2 mm difference between the two globes. So some confusing terminologies along with proptosis include exorbitism, which is reduced bony volume but absolutely normal orbital content. Second is exophthalmos, in which there is protrusion but only due to thyroid disorder. The last is pseudoproptosis. So pseudoproptosis, there's some problem. See the second image, the globe is extremely big, like myopia or bupophthalmos. In the first one, we can see lid retraction on the right side, so it looks like proptosis. The third one, you can see enophthalmos on the right, on the left hand side, and in the last one, you can see facial asymmetry confused as proptosis. So let's talk about evaluation of proptosis. You have to remember the 6 major P's, which include pain, progression, proptosis, palpation, pulsation, and periorbital changes. So first, pain. The first thing that should come to your mind with pain is inflammation or orbital cellulitis. The second could be trauma or orbital hematoma, while others include bone and nerve involvement in a few carcinoma.
The second is progression. It could be sudden onset progression, like in this case of retrobulbar hemorrhage, or it can be gradual in benign tumors, or it can be rapidly progressive in cases of traumatic hematoma, like this kid who came to us with a history of trauma. The third is age of onset. First are infants. In infants, you can very commonly, you can see craniosynostosis as seen in the picture. In childhood, you can see cavernous hemangiomas, while in adulthood, along with thyroid being the most common disorder, we can also have lacrimal gland tumors. The fourth one is progression pattern. First is continuous, slowly it's progressing like a tumor or endocrine exophthalmos, like in the picture we can see thyroid disorder. In the second picture, we can see a very classical fusiform enlargement of the extraocular muscle, in which the tendon is spared as seen in thyroid. Then there is variable proptosis, in which, you can see in this picture, there's no proptosis, but when the patient is doing Valsalva, the proptosis is increasing. While in last, you can see pulsatile proptosis, like in this patient, which is seen in AV aneurysms. We can also ask the patient about diplopia. If the lesion is posterior, generally it leads to some paralysis in the EOM. Anterior can lead to a mechanical restriction, while involvement of muscle tissue, like in myositis, can also lead to diplopia. If there's vision loss, simple optic nerve is involved. We also have to look at the chronology. If vision loss is after vision loss, there's proptosis, look for glioma, while if proptosis is before vision loss, look for meningioma. Now in inspection, proptosis can be axial and non-axial. Axial means it's coming straight up, like an intraconal mass, like cavernous hemangioma, optic nerve glioma, or meningioma, or thyroid disorders. While in non-axial proptosis, it can shift the eyeball up, down, right, left, and center. So in superior displacement, that means either something is pulling it up or pushing it from downstairs. So from downstairs, we have either maxillary sinus or inferior orbital cancers or tumors. Then we have inferomedial, in which we can see there's a big lacrimal gland tumor in the outer temporal quadrant of this patient, and hence the orbit is being displaced inferomedially. In inferolateral, in adults, one of the most common causes is frontoethmoid mucocele, but in this kind of proptosis in adults, in children, please take care of rhabdomyosarcoma. So clinical measurements. First, we have the worm's eye view, where the patient is told to tilt backward. We see from a lower angle, and we see the corneal apices, if anyone is popping out. The second one is Knapsinger. We stand behind the patient, we tell the patient to look behind, we avert the lids, and we again check for the corneal apices. We can look at we can use plastic tuler, which is very economic, very resident friendly. Second, we can use the Lutz exophthalmometer, but my favorite and very expensive is Hertel's exophthalmometer. So in Hertel's exophthalmometer, we have two reflecting prisms along with the foot plate, and you can see that small arc behind. That's what we use to place it on the lateral orbital rims of the patient. So here in this video, you can see the exophthalmometer is placed on the lateral orbital rims. The reflecting, we check. So here you can see a caliper. We see the corneal apex. We look, that's how you measure a proptosis. We look for periocular changes. We palpate and look for retrodisplacement. And there are some knobs. We can do CT to measure proptosis. Thank you.
Can there be bilateral proptosis?
Yes, sir. Most common cause thyroid.
Any other?
So cavernous sinus thrombosis.
Great, thanks.
You can start. So this is the last lecture of the class. Okay, start.
So a very good afternoon everyone. Today we are discussing the management of PCR. I think PCR is something that every surgeon in her lifetime, in his or her lifetime, is going to witness. So but what is basically PCR? PCR PCR is defined as an iatrogenic breach in the continuity of the posterior capsule. How to diagnose it preoperatively and intraoperatively? Preoperatively, there are certain signs by which we can see that posterior capsule is deficient, such as on the slit lamp examination, as in the posterior polar cataracts, we can see a posterior slit beam is bent posteriorly and the discontinuity of the beam is seen. ASOCT, UBM and sheen plug imaging can also be used, but they have some limited role in the preoperative diagnosis. So how to diagnose it intraoperatively? There are certain ominous signs such as deepening of AC, tilted nucleus, red reflex changes, pupillary snap sign, which while doing the surgery we can witness. Then we have to see whether the hyaloid phase is interrupted or whether it is present. To test for that, we can do the sponge test, sweep test, halo test or staining with the triamcinolone. So we will now discuss at every step PCR can occur and how to manage it. First is the hydrodissection. In this video, we can see the pupillary snap sign. While doing the hydrodissection, there is sudden rise in the intracapsular pressure leading to the mydriasis followed by the meiosis, which is known as the pupillary snap sign. ECR during the phacoemulsification is very common, especially while doing the phaco of the last nuclear fragment, because the capsular fornices are empty, allowing the posterior capsule to move forward. And the golden rule is that while the PCR is suspected at the level of the phaco, do not pull your phaco probe outside the eye immediately. First inject the viscoelastic to pressurize the AC, then slowly take it out of the eye. Then the nucleus management. It is done first we take the nucleus to the supracapsular area by the dislodging and the tumbling techniques, and then we extract it from the eye manually or automatedly. In automated technique, it is described by Dr. Amar Agarwal. It is the IOL scaffold technique. In this, first the nuclear material is taken into the supracapsular area, then we place the IOL below the nuclear material, and the other steps of the phacoemulsification are performed above that, the IOL acting as a secondary posterior capsule. Epinucleus and cortex are managed in the similar manner. Now, when all the steps occur, irrigation and aspiration is very much like
aspiration camera, I can see that the posterior capsule gets caught in aspiration probe, and this is a classical sign. Posterior capsule just wrinkles. You can see these star folds or these hydrocarbon-like appearance. At this stage, it's very clear that the posterior capsule is caught. One thing to do here is never move the aspiration hand. It's just wait still and then press the reflex button on your foot.
And during the IOL implantation, PCR occurs due to the forceful delivery, direct trauma from the IOL haptic, and the AC will become shallow. How do we manage it? We will do the viscofluid exchange, and to see whether the vitreous is coming or not, we will stain with the triamcinolone. And if the vitreous is coming, we will do the anterior vitrectomy, and then after doing the viscofluid exchange, we will place the IOL. IOL implantation is done if the anterior highlight face is intact or not. If the anterior highlight face is intact and the capsular support is present, then we place the IOL in the capsule. And if the IOL capsular support is not present, then we place it in the AC, iris fixated, scleral fixated, and the choice depends upon the capsular support and the vitreous status. So prevention is the best form of the management. IOL choice is individualized, gentle handling, viscoelastic support and vitrectomy should be done when needed, and we should always collaborate with our posterior segment surgeon.
Do you know flap motility?
Sir, if we talk about the single IOL, then we should place 3-piece IOL. If the vitreous support is present and the capsule is intact, then we can use the single-piece IOL. But if there is no vitreous support, then we can place the AC IOL. 3-piece IOL is used. Iris claw lens can also be used.
Retrofix or anterior?
So then we have to see whether iris chafing has been done or not. If it is iris is in the good place, then we can do it in the AC also.
Do you know anything about flap motility sign?
So when we are doing the phaco, the epinuclear plate is coming. Epinuclear plate comes out towards the phaco probe. That is known as the flap motility sign.
Okay. Students can read and come next time prepared. Yeah. Okay. So I think let's we. So okay, so thank you so much. I think you did a great job, and thank you to all the students for being here till the end of the session, and thank you for the judges, the senior students, for have the patience, and thank you to Professor Namda Sharma ma'am. She allows us to do this program each year, and that's a big thing. I request her to say a few words. Meanwhile, the judges can tally the score and they can announce the winner.
You are using me as a filler so that judges can do the result. I think it's a great program, teacher of teachers. And what I think is that, I mean, I saw only the last one, but I know I've seen others also. The students, they prepare far better than teachers, because we take, I think, for granted and we say, okay, we will manage. But they have, the last one was quite good, and they prepare so well because they do entire research, then all the graphics, they put their heart and soul into the only presentation they have got as a teacher, because they have to make their teacher proud. And I think that used to always happen for us also. I always thought I made better slides for my seniors and for my teachers than what I make for myself. And I used to spend more time, making their slides than the time I actually devote to my slides. So that thing is there, and students are at this age and at this stage when their enthusiasm is 100+, and when their will to do anything and their the passion with which they do, at that stage, you feel you can do anything. Sky is the limit. So I think this is a great program that way. Also, it helps, I think, for as far as the students are concerned, they also would be in their heart of hearts, thinking whether they are teachers and they want to go into academics or they want to go into private practice. And I'm sure all of them who want to go into academics are the teachers today. Munish, I wanted to congratulate you for your student who really presented well. I feel very proud because Munish is my student, I should say. So once a student is always a student, so also for Praful, he will always remain a student, although he is conducting the program and excellent. I'm sure all of you must have presented very well in your own style, and we pick up so many things, how to present from you also. So it is the other way around because you only teach us. So it's a very good program, and thank you, Praful, for conducting it year after year, conference after conference, and thank you all the judges. I think very difficult to judge somebody else's students and other teachers when you are sitting in that wearing that judge's cap. So thank you. You have the results? Or
Yes,
should
ma'am.
I
Thank you,
step
ma'am.
forward?
And I request you to stay there only and judges to come forward so that we can distribute the medals. Now comes the most
Before
different
you
part.
announce the result, I would like to congratulate all because in 3.5 minutes, giving that extensive management of retinal detachment, management of acute
PCR.
NLD block and acute optic neuritis is really difficult, and I think everybody has done a fantastic job. Like when we were student, we were not that confident. You were all so confident and presented so well. So congratulations to all. You all are winners.
So this is what I was about to tell. Ki this comes like it comes. This is the most painful part. If given me an opportunity, I would have given gold medal to all of you, but I cannot do that. So judges have finally decided which team is the winner. So I will like to start with the first runner-up. Okay. So first runner-up is team GGS Glare Busters. Mentor is Dr. Munish Dhawan, and the mentees are Twinkle Gupta and Pranisha Gupta. Please come here, sir. Bronze medal.
Munish, पहले तुम आओ.
गले में डालना पड़ेगा आपको. मैं अनाउंस करूंगा. मेंटर का आप डाल दो, बाकी सब डाल दो. So the runner-up, okay. So runner-up is team UCMS Mavericks, mentor Ankur Singh, mentees Krati Gupta and Pragya Gupta. वो आया ही नहीं. सी मेंटर को बोलो 2 मिनट में भाग के आया, नहीं तो नहीं मिल रहा तुम्हें मेडल. फोन करो. हाँ बिल्कुल. अंकुर को बोलो भाग के आए. I know. So the winner team for today's TOT, this media, सबसे ज़्यादा जो म्यूजिक चलाएगा उसी को मिलेगा और क्या Gen Z. So it's Team Maurya's Master Blaster. Mentor is Arvind Maurya, Manish Mahima Kaushal, and Banka Megha Ajay.